our presenter today. It is with great pleasure that I get to introduce our June presenter, who's going to talk about teaching with simulation in neurosurgery. So Dr. Ashish Kumar is a neurosurgeon at Sunnybrook Health Sciences Center and is cross-appointed as an assistant professor in the Faculty of Medicine at the University of Toronto. He joined the Division of Neurosurgery as a surgeon educator, and his field of expertise is in cerebrovascular and endovascular surgery with open cerebrovascular training at the Fujita Health University in Nagoya, Japan. And he's also had fellowships at the University of Toronto. In 2022, Ashish graduated from the Education Scholars Program, so he and I were in that cohort, and I can attest to his brilliance. He continued his interest in health professions education as he joined the master's program at the Dalai Lama School of Public Health. And recently, Dr. Kumar has been involved in many education scholarship endeavors at Sunnybrook Health Sciences Center. He's been recently appointed as the faculty lead for undergraduate medical education, and he's also the site director for the neurosurgery residency program and supervises the Advanced Microneurosurgery Fellowship. He was appointed as Education Committee Chair at, is it Fujita or Fujita? Fujita Health University Alumni Association, which is closely associated with the Asian Congress of Neurological Surgeons, or the ACNS, where he also serves as an executive committee member. As an advocate for Toronto neurosurgery, he desires to develop strong educational interactions and opportunities between North American and Asian neurosurgical societies. As a teacher, his main interest is to increase exposure to and foster neurosurgical residents' interest in endovascular neurosurgery through the development of a core curriculum in the specialty, simulation protocols for dual training, and optimal cerebrovascular exposure during neurosurgical residency. So thank you so much for gracing us with your presence today, Ashish, and the floor is yours.
Thanks, Petal. First of all, thank you so much for inviting me to SimCity rounds. It's just a pleasure to go across, and come outside your neurosurgery sphere and interact with a lot of colleagues, educators from different, specialities and disciplines, a thing which I learned in ESP so well. And I'm glad we are able to, just continue the same concept over, our respective hospital zones and works. So I'm going to share the screen. Okay. Can you see it? Perfect. Okay. So, yes, thank you for that introduction as well, Petal. What I'm going to do is I'm going to basically talk about simulation. Simulation is also very close to my heart as an educator, because that's where you can actually teach your trainees a little bit more than what you do in neurosurgery OR, where probably the stakes are a little bit high. And in my opinion, simulation should be part and parcel of every training program. Like at Sunnybrook here at plastic surgery, we are able to, I think the plastic surgeons are able to do weekly simulation rounds, which I came to know last week, and which is actually a very, very good precedent. If we can do an hour of simulation every week with our trainees, I think they will get better over the period of time. So that is something which I'm looking forward to, and hopefully we'll have our own small little surgical skills center here in the next few months. So in this talk, what I'm going to do is I'm going to define simulation, just a basic definition. We will also review the history of simulation, and I will say like surgical simulation, how it started and how it gained popularity. We will also discuss the simulation modalities in healthcare with a special focus in neurosurgery. I'll be able to tell what we have done in terms of vascular neurosurgery or endovascular neurosurgery simulation at University of Toronto, and we'll kind of touch upon some pros and cons of surgical simulation. So simulation by definition is the promotion of understanding through doing, and also offering the opportunity to merge theory with the practice. All of you are aware of this definition, but simulation is also defined as an instructional process that substitutes real patient encounters with artificial models, live actors, or virtual reality patients. Learning activities that can be made safer, predictable, consistent, standardized, and reproducible. So these are the two standard definition of simulation. But when we go back in history, and this was a paper actually in Child's Nervous System, which is a neurosurgical journal, and I actually learned a lot from this paper because they went back into the history of simulation, and they said like the simulation was always there. It was at the time of Achilles when they are playing a board game for designing military tactics, or in 1812 where Germans are playing this official game, which is called as Kriegspiel, which is like a war game, again, something related to the military tactics. But subsequently, Herophilus was the first one who actually led to significant advancement in human simulation, where he encouraged human cadaveric studies. So that started the cadaveric simulation, which we see very common these days, and followed by, Leonardo da Vinci, who started injecting blood vessels with wax so that they can preserve and study the anatomy very well. Andreas Vesalius was the founder of modern human anatomy, which basically came out of Herophilus' work, and he established the systematic cadaveric dissection, which started in our medical schools, and then first kind of synthetic human trainer was devised by Lirdl in early 90s, and that started the whole revolution around synthetic trainers or virtual models, if I say. Simulation in training, we know, has gained widespread acceptance in many fields, started from aviation safety, and it has incorporated multiple specialties. And in medicine now, it's very commonly seen in all the specialties. Especially in neurosurgery, it becomes very important because it's a high-stakes specialty, and we are very, very careful to make sure that the margin of errors stay small, and we are able to achieve the outcomes without causing minimal deficits or morbidity to our patients, because we know that mistakes and failures can have disastrous consequences. Now, benefits of simulation, you all know, but I'll just briefly mention here because, simulation actually exposes you to rare and dangerous situations without being in that situation in actual life, allows for team training, helps in communication, builds confidence. You can reproduce the learning during a post-event debrief. I'll talk about surgical debrief, which is usually a little different from other specialties, but it helps you to teach technical skills, and it basically provides you a safe and brave space for learning where there's no harm to the patient, and it's much safer. You can plan the learning objectives, you can be more predictable, and you can be very focused on one particular part of, for example, surgery, which you are dealing with. So it has significant benefits, and that's why it's been used in healthcare in many, many ways. There are various different models across specialties, across disciplines, clinical examination model, part task trainers, real procedural simulators, hybrid simulators, live models, and cadaveric models, screen-based simulation, mannequins, standardized patients, virtual patients. There are a lot of options available if someone wants to start a simulation facility at a particular center. But in terms of surgery, I think these four are the main cornerstones of surgical simulation. Since the age of, in the early 1900s, like we always wanted to do more hands-on tissue training, which will give you the more realistic feel of how it will look when you are in actual surgery. So I think simulators have been popular, but if you ask any neurosurgical training, they would love to operate on a cadaver. So because that gives them the most, high fidelity experience, I will say, for surgical simulation. Now, in terms of simulation in neurosurgery, do you think our neurosurgeons feel that they can still improve with simulation? So I know this is true for everyone, every specialty, that simulation is proven to be very beneficial. But in neurosurgery, sometimes surgeons feel like they're above everyone else. They know what they are doing. Come what may, we'll be able to do it. We'll be able to tackle it. So this kind of what I call as God complex is very common in neurosurgery, and it becomes a part and parcel of your personality as you go up. But if you ask them that if they can do a surgery which happens once in a lifetime, or maybe they have just read about it and have not actually done it, can they do it? And normally the response will be like this.
I love this song, but I can't hear the audio properly. I think you have to enhance your audio in
Oh,
Zoom. But good. Thankfully, I think many of us know the song.
exactly. So the perception is like if you are able to do this in day-to-day life, neurosurgery, probably you will be able to do this with your eyes closed. But if you are actually doing a case like this, which happens once in every one's lifetime, especially in pediatric neurosurgery or craniopagus surgery, where there are three-year-old patients who are like in this case who were separated in a couple of years back in a long surgery, where the surgery actually happened in Brazil and the simulation was happening through virtual reality from UK, then this kind of surgeries you cannot do with your eyes closed. So that means that there is a need for training. There is a need for significant multiple iterations of the same surgery on models before you can actually touch a patient who is 3 years old and needs to be, needs to undergo this kind of very technically nuanced surgery. So this surgery, as I said, happened a couple of years back. The surgeon was mentoring through virtual reality in UK, and the surgery was very successful. And conjoined twin surgery is always, I will say, one of the most toughest challenges you face in pediatric neurosurgery, especially. And
Extraordinary. Now, just take me through
this is
the
the
planning, because I
surgeon
know there
who's
was a
talking about
huge
the
amount
surgical
of
simulation.
planning using virtual reality, using models. Just tell me more about how you thought it through and prepared for all of this.
Sure. So it's quite a complex task, but with any complex task, what we do is break it down into smaller, more manageable steps. So how do you deal with the brain? How do you deal with the blood vessels, the skin, the bone, the covering of the brain? And when you think about it in that format, you can then make strategies and plans for every single step. The task then is, okay, we've got all the various pieces, we know what to do at various stages, how do you put it all together? And that requires practice, simulations, which is what we did over a 6-month period.
And just briefly, because we're seeing, models of the brain and the blood vessels, when you were practicing, and did the team get it wrong on occasions?
In the practice, a number of times. And that's the whole idea of the practice and why we need to do it. So you run a simulation. If you end up in a dead end, you say, okay, this was the wrong strategy at this point. We'll come back. Perhaps let's tackle this part from this angle first. And that's the whole idea of running these simulations. But what we were able to do this time around, which is a world first, is to do it in virtual reality across the 2 continents with us setting it up on our platform.
So this was an example of how simulation actually helped someone across the continent. And that's why I said simulation neurosurgery has come up recently as a training tool, because it, one, reduces exposure of trainings to surgical cases based on residency duty or restrictions. They can come anytime, practice, and they can gain access to those procedures which otherwise in real life they'll not be able to do. And plus, with the help of these kind of advances in imaging, computation, virtual reality, 3D printing, you can have those models prepared and you can practice again and again. It basically allows you to have a practice swing before actually hitting the ball. This was my first simulation, not a real life simulation, but Pital knows about this because we discussed this in our rounds before. This was me practicing microvascular anastomosis on chicken wings. Of course, there's no blood there, so it's a very low fidelity model.
And then I suggested you should add some ketchup to increase the fidelity on those chicken wings.
Exactly. So we used to do this, and I'm talking about like 15 years back, and at least it gave us some idea about how the vessels look under high magnification and how you can actually have that feel of anastomosing small vessels. So simulation neurosurgery came up, I will say, in last decade or so. And this was some of the early work in terms of needs assessment. Like this survey basically surveyed 99 US neurosurgery program directors, and they basically asked them, like, what do you think simulation's role in neurosurgical trainees and their education? So if you see here, they basically on the left side, they say like most of the program directors agreed that the use of simulator will actually improve patient outcomes. But when you ask them that, oh, do you think this is going to kind of replace some of the aspects of conventional surgical training? The answer was more towards, not sure, maybe it will not, kind of replace certain aspects. It can be an addition, but that has changed. And I'll come back to that at the end, how that has changed. Earlier, there was a lot of resistance that this will actually kind of it can be just a very, very artificial or low fidelity way of teaching neurosurgery. It may not replace some of the things which we do in surgery, which is correct, but it has changed. And as I said, simulation in neurosurgery has skyrocketed since then. This was a paper, the earlier paper was in 2013, and that was the early part of the decade where a lot of simulation centers were coming up in neurosurgery. And now, if you ask, there have been significant training interventions, and they align with the ACGME core competencies. And you can see on the left side of the screen, even if you have a cadaveric dissections, you have physical models, you have augmented virtual reality, you have high fidelity mannequins, and you have patient actors. So this slide itself tells you that each modality of simulation actually can cover many core competencies. A good example, for example, is physical model, which is very, very popular in surgical residents and trainees, where they will actually have an equal amount of exposure to patient care and procedural skills, medical knowledge, and practice-based learning and improvement competencies. So this is a very, very important slide, which actually summarizes the concept behind the simulation and training interventions. We know that simulation is basically based on Kolb's cycle and experiential learning theory, where simulated scenario and debriefing afterwards will add to a certain degree of practice change. And it has to be a repetitive process, which will actually help in our trainees getting more confident in complex procedures. And a recent review, which was done in 2020, published in 2021, basically talks about what kind of surgical skills stations and training opportunities exist for neurosurgery, and whether there is a significant effect of the recent uprise in simulation in terms of patients' outcome. So if you see here, they basically, this review was done, and they actually identified around 7,000 studies, out of which around 56 studied met the inclusion criteria. And their simulation types included cadaveric simulation, low fidelity models, to virtual simulators. And the 32 studies which were actually included in the meta-analysis had actually 7 RCTs. So again, this is something which has come up recently. RCTs were not existent that much in surgical simulation before, but has been part of the literature recently. Now, when they reviewed it, they actually documented significant improvement in procedural knowledge, technical skill, as well as increasing the speed of the particular surgery. So this was, the kind of simulation which is available at this point of time, and this was nicely summarized in this meta-analysis. Cranial, spinal, and even in cranial neurosurgery, you can have functional simulation, you can have simulation for hydrocephalus, neuro-oncology, skull-base, vascular, and also you can have significant, kind of model training on spinal neurosurgery, be it pediatric, adult. So a total number of articles which were selected were 56 in this study. And these are some of the examples which have come up, I will say, as I said, like in the last few years, on where the students can practice microvascular anastomosis. This looks better than the chicken wing because it's a real vessel and it has blood in it. And you can see it's connected with a pump, which will actually continue to provide red-colored blood, which will flow across through the placenta models. And you can see it recorded at the same time as you're doing. Rigid models, like doing it on plastic tubes, suturing practice on piece of glove with high zoom resolution, zoomed on videos, along with 10 sutures, will give you a very good idea about how it will look in real life. Dissection on animals, on rats, is also part and parcel of all vascular neurosurgery courses these days, and you will usually have 1 or 2 days of pre-conference workshop, which will have these kind of either cadaveric or vascular workshops. Endoscopic workshops, endoscopic models on hydrocephalus is, again, virtual reality has come up in big way, which will kind of give you a simulated scenario of where the ventricle is and what will be your proper trajectory to go inside and make an opening to help a patient with hydrocephalus. Virtual reality model, as I said, they have come up recently, and they basically tell you and show the anatomy based on a patient's particular CT angiogram, and you can actually go through it and visualize all the anatomical structures, which you will see. The only thing in these situations is when you are doing these virtual reality models and you are operating on or you're performing in a simulation lab, it does not account for the compression factor or the elasticity of the tissues. So it may give you a false impression that everything is right in front and it will be so easy to dissect and reflect, but actually that part is still missing in many of the virtual models. Endovascular simulation, I am an endovascular surgeon, I do a lot of endovascular surgeries. It has come up again in the last 5 to 7 years, where a resident who is usually not a part of angiographic suite, because usually this is a fellowship-based specialty, but they can also come and see, and they can practice on a simulator. They will know how to do an angiogram, how to catheterize these vessels. And this study, for example, demonstrated that over the period of 5 subsequent trials, residents, like their actions, their techniques, they actually improved. And those who were initially were in the dangerous zone, or they were doing maneuvers which were dangerous, they corrected over the period of time. This is our own endovascular simulation models. We do this at Mount Sinai Lab once every year. This is a PGY3 course, and you can also see a simulation model for endovascular simulation. It looks like this, where a catheter and a wire is inserted at one end, and will really look like you're working under an imaging intensifier. And with the help of that, we try to incorporate both endovascular and open neurosurgical courses together. So now that course contains both microvascular anastomosis on turkey thighs and cadaveric skull-based dissection for our surgical traditional approaches, along with hybrid courses as well. So this is especially done for our third-year residents, and it's a earmark course because earlier there was only open cadaveric dissections, and now we have included the endovascular simulator, so it becomes like a hybrid workshop. So I was talking about the initial simulation where we thought that probably there is not much of interest in neurosurgical community regarding simulation. And this was like in the earlier 2013. There was a recent simulation-based survey. Again, same program directors in US, all across US were surveyed. And now if you see the difference, you can actually see almost 80 to 90% of the program directors think that the simulation helps in learning anatomy, learning new surgical techniques. They allow trainees to become more comfortable with technology, and they allow them to actually prepare for a complex surgery. It is also being used for assessment of competencies, though not very commonly. You can see in the same paper, they're talking about the feedback, and the feedback in surgical specialties usually is found wanting after many such simulation scenarios. You will see the simulation, the feedback was almost 54% always, but there's a big component of sometimes, which like almost 40% of program directors thought the feedback only happens occasionally or sometimes. So that component is probably the Achilles heel of surgical simulation, where there's not a proper debriefing which happens after every such case. When you are doing a practice on model or on cadaver head, all the feedback which you get is basically from your own self-belief that you're able to approach a particular anatomical structure. And somebody will say, like in verbal debriefing, is like, oh, you did a good job because you exposed everything. But basically talking about each micro step and dividing that whole exercise into multiple small segments, that does not happen very frequently in surgical simulation, and which needs to happen in future, because that's how you will probably work more on their microsurgical skills rather than achieving a particular target, which they will achieve anyways because it's a cadaver head. So again, as you can see, verbal debriefing was the main component of feedback. Recording, playback videos, they did not exist much, and most of the simulation, as I said, was very popularly in cadavers. The mannequins and physical models were the next one. Virtual reality and mixed augmented reality were the next ones. The good thing about this paper was that you could see on the right hand side there were a lot of simulation which were like not just yearly like I do at this point of time, but they were weekly, they were monthly, every 3 months, every 6 months. And you can see like there's a fair bit of simulation happening every week or every month. Like I said, in plastic surgery, I intend to do that here at Sunnybrook for our neurosurgery trainees. If you are doing it every weekly, I think it has a different impact than if you do it like after a certain time, because surgical decay is very, very common in neurosurgery. So When we talk about any drawbacks, simulation also, we spoke about the advantages of the whole process, but are there any drawbacks? Yes. Physical models, they are costly. How you get them is a big issue. We are trying to do a rookie camp for our neurosurgery residents in first year, next year, hopefully. And we are already struggling with finding the cadaver heads. So how to get them, how to dispose them safely. When they get to you, are they soft or the tissues are rigid? It's a different challenge which comes with cadaver heads, although these are the most popular way of surgical simulation. Virtual reality models, which are based on CT, MRI, and pictures, they are difficult to, as I said, they are difficult to reproduce elasticity due to tissue deformation. You can actually go and operate on them, but you will not have the actual feel of tissue dissection or tissue deformation. Mixed reality model actually will be the best combination of both of them. And you will probably have a patient scenario along with a virtual reality model, so you can actually do a combined both hands-on cadaveric dissection or on a artificial simulator model. But if you have virtual reality, you can combine them. But again, this is resources intensive and is expensive at this point of time. We talk about cadavers as the best surgical simulation, and everyone likes to play with the actual tissue rather than rather than a model which is synthetic. But cadavers do not actually translate into a real knowledge upliftment for the residents. This is a review which was done like 10 years back, but it actually showcased this very important fact that when they did a systematic review, they found around 8 studies which were actually included and as per the eligibility criteria, and only 1 study showed a benefit from a cadaveric workshop into clinical space. So when they did this, they actually found 8 articles, and only 1 of the studies, also 2 of the studies were actually helpful in translating what they learned in the cadaveric dissection course into an operating room if they asked them to do the same procedure one week after. So this kind of study was very useful because they actually did an actual clinical test after 1 week of that cadaveric session. Normally, what happens in cadaveric workshops, there is usually, you do a cadaveric workshop, you do very well, you feel like, oh, I'm ready to operate next day. But after a certain time, it just not in the mind, you are not ready for it. And if a similar situation comes in the actual operating room, probably you will not work or you will not operate in the same way as you were thinking you were in the lab. So I think it is useful, and it is still the best way of teaching neuroanatomy and dissection skills with the tissues. But if you actually try to see if it really helps in the OR after a certain time, I'm not sure whether this is that much helpful. Again, most important part which we don't know is about the human component, like the real life pressure cooker situation. When you are operating on an aneurysm, you probably will be very different. You will be behaving differently than what you did in a lab, because there's no active blood flow into that aneurysm. There's no pulse beat. You cannot see the blood flowing through the arteries. And that's why human component becomes very important in all simulation scenarios. You can see, I think you will remember Captain Sully. And I think this is a clip which I actually love to share when we talk about drawbacks of simulation. And I'll see if it plays here.
50, 40, 30, 20.
Successful landing at Teterboro, runway 19.
Multiple airports, runways, 2 successful landings. We are simply mimicking what the computer already told us.
A lot of toes were stepped on in order to set this up for today. And frankly, I really don't know what you gentlemen plan to gain by it.
Can we get serious now?
Captain?
We've all heard about the computer simulations, and now we are watching actual sims, but I can't quite believe you still have not taken into account the human factor.
Human piloted simulations showed that you could make it back to the airport.
No, they don't. These pilots were not behaving like human beings, like people who are experiencing this for the first time.
Well, they may not be reacting like you did.
Immediately after the bird strike, they are turning back for the airport, just as in the computer sims, correct?
That is correct.
They obviously knew the turn and exactly what heading to fly. They did not run a check. They did not switch on the APU.
They had all the same parameters that you faced.
No one warned us. No one said you are going to lose both engines at a lower altitude than any jet in history. But be cool. Just make a left turn for LaGuardia like you're going back to pick up the milk.
So we know that when the real situation comes and when you're operating on a real patient, the situation will be very, very different than what you're learning in simulation. And that actually translates more into surgical specialties when you are doing a very complex surgery, because the whole scenario will be very different, and you will be working with your adrenaline probably pumping through your veins, and you are worried about causing complications. Then probably your behavior will also change. And that's what this clip was all about. And I love this to just show that simulation is great, but simulation may not be completely achieving what we want to achieve, but maybe someday in future we'll have that combination as well. So we know that the limitations of simulations, that they can be resource intensive, they lack authenticity, especially the low fidelity models. They require space, they require personnel, they are technology dependent. And of course you need like sim experts, teachers, faculties to come to your courses and teach the trainees. And trainees need to travel again, to get to organize a surgical simulation exercise becomes a big deal, because then you have to look into all these factors before you can, plan a course. It's not like this when I'm doing on a chicken wing versus this, which is a real life microvascular anastomosis. These two things are completely different, although they look same. But that's second picture is about a real life scenario where a little bit of movement can actually damage that blood vessel which you are trying to suture in. Now, what's in the future? For the future, I will say there are a lot of new simulation models coming up. And this was actually an article published in Globe and Mail where a surgeon who I know actually from a neurosurgeon from Montreal is actually working on a model which is completely based on virtual reality. So there's no tissue involved, there are no cadavers which are involved, but it will give you as real as tissue feeling as if you are doing on a cadaver dissection. So that this model is called as NeuroVR, and it behaves like something like this, where with the help of your suction and bipolar, which you hold when you are doing a surgery, you can actually feel how much tumor you are removing, and will give you that haptic feedback, which you otherwise will not gain through a virtual reality model. So this is what was lacking in virtual realities, and hopefully this little modification will improve the feel of the surgery, because most of the trainees, they want to do this, but they want to do this in the most realistic manner. So they want to have that feel of removing the tumor or dissecting the tissues, and that can be done only if there's a combination of a physical simulation model versus a virtual reality model, or a virtual reality model like NeuroVR, which gives you the most important, which is just gives you the haptic feedback as well. So there's a
demonstrates the simulated tumor removal task using the NeuroTouch neurosurgical simulation system. The task is started by clicking the virtual start button with the tips of both instruments together. The participants were instructed to remove as much of the tumor as possible while sparing surrounding brain tissue under the maximum allotted time of 3 minutes per tumor. The dark-appearing tumor is meant to mimic melanoma metastasis to the brain. Here we see the participant using 2 instruments for the resection task.
And this is actually a real-life scenario. We are using a suction on the left hand, and you're using an ultrasonic aspirator to dissect the tumor. But now what you are seeing in this model is that there is actual bleeding happening, and that bleeding won't stop unless you actually coagulate it. So the surgery will not proceed further if you are not taking the necessary steps. So
The ultrasonic aspirator is held in the dominant hand, while the sucker is held in the non-dominant hand. We can see how the tissue responds in real time to manipulation by the participant. The tumor resection is carried out with the ultrasonic aspirator, while the sucker is used to control the bleeding. Bleeding will continue to occur until its source has been fully removed. After the left tumor has been completely resected, the participant goes on to remove the right tumor. For all scenaria, the left tumor was higher stiffness than the right. Finally, during the task, a variety of metrics are recorded in real time by the system. To finish the scenario, the participant touches the stop button with both instrument tips.
So you can see actually with this kind of model, you can actually differentiate between the firmness of the tumors also. So a tumor on the left side was soft and it was easily suckable, while on the right side it was more firm. So you can actually make that differentiation, which is very, very hard to actually do through virtual reality. So these models are coming up in future. But again, as I said, in the same article, somebody asked me how you think this is going to work. I said, like, if you're not doing anything, this is really, really good. But it can give you a small sense of confidence that you are very good in simulation. But when the real-time surgery comes, you may not perform that well. But it's still better than nothing. And the alternative is just like watching. So I think experienced surgeons like us also need to benefit from simulation, because if you have a lab at your center or if your hospital, if you are doing a surgery which is not very routinely done, it's good to go and practice, a day before it, along with your trainees, and the whole team have an idea that what they are going to, encounter during the actual surgery. So in my opinion, this is actually very, very useful, and hopefully this model, because this is done by Dr. Del Mastro, who is a neurosurgeon at McGill, will become commercially available in future. And hopefully we can bring it on and try to see if we can provide this for our trainees. This is something which I'm looking forward to, which is not just virtual reality, but virtual reality with real-time tissue feedback. So this brings to the last slide of my presentation, where I'll say, in surgical specialty, especially neurosurgery, I think simulation has come up a long way. It is incorporated in neurosurgery curriculum. You can see workshops before every conferences or any teaching courses. As I say, I do it once in a year for all PGY3 residents, but I understand it needs to be more frequent to really, really gain something from it. It has become an adjunct to in traditional neurosurgery teaching. There's no doubt about it. There are a lot of things which you can learn on cadaveric dissections, and you can actually replicate the same thing during the surgery. So I think this is going to replace some part of neurosurgical training if we make it very frequent, if we make it very, very commonly and frequently done. Clinical translation into making a procedure safe and quick is for sure that happens in surgical specialties. And then you can actually assess the trainee speed, the amount of blood loss which happened during the surgery, or the false steps which were encountered during the procedure. Everything is recorded, and you can actually see them, how they get better by doing same simulation again and again, week after week, so that they get better with all those touch points where they were not performing well earlier. So I think this has, in surgical specialty, especially neurosurgery, every specialty will have significant number of models coming up in future, which will help our trainees to train and practice better, because it will be difficult to practice directly on the patients. So that is something which I'm looking forward to, and hopefully the future is bright. Thank you so much.
Thank you so much, Ashish. That was amazing, informative, and certainly out of my wheelhouse. We have one question in the chat from Fabienne. She was wondering how you get to practice the impact of elasticity and compression. Do simulators, like you're mentioning, work for this, or are there limitations of what any sim can provide, even with live animal models, etc., that can only be experienced by real practice?
Yeah, so it depends on cadaveric models. So cadaveric models can be very well prepared and maintained. versus cadaveric models can be frozen in a not so appropriate manner. So if you are actually doing them, if it depends on how they have been preserved. If they are frozen, then you probably cannot, replicate that elasticity and tissue deformation. And you will have to actually pull them in a non-realistic way. Again, then they lose their, kind of replication in the original surgery, which you do in the OR. But it also depends on what the tissue is coming from, whether it's well preserved. There are very good models which give you exact replication of the tissue elasticity which a normal brain has if they are prepared well. So that's why the models becomes expensive. The models we are using, they're coming from US, and there are two different types of model. One is like nicely embalmed and very nicely frozen. You can actually feel that you can nicely dissect the tissues. The other ones are like stone, so you have to literally retract the brain tissue to reach to a particular anatomical structure. So I think in cadavers, it depends on how the cadavers are prepared. But in virtual reality, there are now models which will actually, hopefully, give you an idea about tissue firmness. And if you deform a particular tissue, and based on that, how the anatomy changes, I think those softwares are coming up as well. So it's like more at that moment, if you kind of retract a particular tissue and how it changes the anatomy again, rather than a fixed anatomy, that whatever I do, it's not going to change. I think that model is coming up as well. So these are some virtual reality software models I'm talking about.
Mark has a question for you.
So nice to see you. We work at the same hospital, but never
Never
see each other.
I have seen your concert notes. I have seen,
I
we have communicated through emails, but the first time I'm seeing you in real life. So
yeah,
Mark, you gotta go check out his office for me and take pictures.
yeah, I'll do the Neuro VR. So I've got three quick. Like this is the first. Congratulations on your scholarly approach to this. It was an excellent talk. Is the Neuro VR cost, like, can you comment on the cost of doing the VR sims, and is that less expensive?
I think right now in our surgical sim center, we have only one VR goggles. It's not fully incorporated. It is resource expensive. Like it's expensive. Like it has some. We have probably ordered like 6 such classes, but like Neuro VR is a different level of surgical simulation. That's something which has come up like last year, for example. That article was like September 2023. So I'm not sure actually how much it costs, but it is right now probably in some stage of development where it will be commercially available soon. But it will be expensive, Mark. There is no doubt about it, because that gives you, it's not just a VR, it's like a VR with a realistic touch, where you can actually decide whether you want to make the tissue firm, you want to make it soft, how you want to differentiate between the two types. So it gives you the actual feeling. I'm expecting that it will be costly. I don't know the exact cost because I don't think so it's commercially available.
Yeah. I was looking at the Royal College website. There are 61 there are 39 procedures, competencies that the neurosurgery residents have to achieve. And then I saw another article about EPAs. There are 61 neurosurgical EPAs, 20 surgical foundations EPAs, so 220 assessments over a residency. So it's a lot. To what degree does the Royal College or U of T allow some leeway that some of this can be done through sim? Because I can't imagine that even in a 5-year training you're going to get all the surgical treatment of Chiari malformations plus there's certain things that you'll do all the time, but bone harvesting, occipital cervical spinal instrumentation, like all of these are not going to come up every day. And maybe some of them won't come up but once every couple years, and they have to be, what if they're not on service that day? So what does the Royal College and U of T have to say about using sims to achieve this huge number of competencies?
I'm telling you, Mark, this is like a pain point for me, because I'm trying to get this surgical simulation not once a year, but in fact more commonly than that. But the problem here is that there's no link for the EPAs in the real life versus what you are practicing on simulation. So if somebody says, hey, this person or this resident did very well in surgical simulation, maybe perhaps he's ready to at least start off some of the steps of the actual surgery, it has no meaning to it. So these two things are completely separate. And I think simulation at this point of time is more like in departments, in our divisions, we do courses, but it is not incorporated on an ongoing basis. The first time I heard, I was speaking to Laura Snell in plastics, and they have a Wednesday sim session every week before what, 7 to 7:45, they'll practice a step, they'll practice a particular step. So that kind of doing it again and again, that iterative approach, I think that makes it much better. But if somebody did very well on simulation, it has, I don't think so, any meaning or any repercussion on your EPAs or on your, kind of evaluations. You can have your own evaluations for simulation, and you can tell them that this person is very good or not very good, or he's improving or she's improving. But I don't think so it has any implications to Royal College evaluations or assessments, which is, it should be, right? Because makes sense, but it's not that common.
So it may be that the attitude is that this is so different from the real world. Like what really counts is the real patient. Sim is nice, but and so then it gets me thinking, maybe is it useful for the resident who is struggling with skills, right? Like who is not passing these competencies, is having some basic struggles, so then they can have a remediation plan where they can build up some of the foundational skills before they're allowed back with the patient. Like, is that, yeah.
That's a very good idea. The thing is, if I have to go and work with someone in a sim lab, the first thing you say, okay, where do you go? There's nothing in hospital. There's you have to book a surgical skill lab downtown. And now we have a missioner, which is very good, but is expensive. So where do you go, first of all, whether you have some in-house facility? Second, the residents and the trainees are so busy in their day-to-day work to take time out from their own schedule for their own benefit becomes difficult. And then, there is this whole idea about, as you said, oh, it's not the real deal. I can do whatever I want to do in simulation, but it will not be same as in real life scenario. But most of us forget that, at least these baby steps or these micro steps, which you actually can learn in a simulation, will go a long way in at least, establishing the self-esteem of a particular learner. So I think it is very useful for those who are struggling. It will give them a very, very good, relatively good, hands-on experience and say, okay, I can at least do this part and let me try back again and see if I improved. But at this point of time, there's no way to assess that clinical translation because there are not many resources. There's not many opportunities on day-to-day residency trainings, right? Doing a course once in a year, I'm good. It's nice. I feel very good when I do this because I'm doing open tissue dissection, anastomosis, and endovascular simulation. But you ask after 1 month of that course whether you actually gain something, the answer will be probably no, because they will forget about it the next day. And that's why these cadaver models, they're good when you are in there, but they do not translate very well in long-term, kind of translation into skill acquisition, unless you do it so many times again.
Thank you.
Thanks, Mark. Thanks for your comments. Very insightful.
I mean, since it's a small group, I'll just jump in instead of raising my hand. But just as you were mentioning about skill, attrition of skill and skill loss and stuff like that, I was thinking we just published a paper at so I work in CAMH, a mental health field. I actually just did a psychiatric sim with Mark and Petal this morning. So vastly different field. It's been very interesting for me to hear about so many things that feel familiar, like Kolb's and virtual reality. I created some trainings with folks in that as well, and then hearing how vastly different it is in your field than mine, which has been very cool and very eye-opening. So thank you for that. But I just wanted to add on the sort of the loss of skill. We just published a paper on physical skills right? So if you're thinking about like safety skills for crisis intervention with patients or something like that, and we tested a couple different approaches to training, and the attrition after 30 days was frightening. Frightening, right? Like we're at like 60 to 80%, generally speaking, roughly, regardless of which training approach we gave. So just kind of speaking to what your point is, and that's the same type of points we're trying to make is like, hey, once in a while is great, but like if it's for skills that we need regularly and that are important, a one-off training, like it doesn't work. That's not, yeah. So I just wanted to, yeah, it's great.
Oh, thank you for your comment. Actually, surgical decay is an official term, which when I went through the literature about simulation, because I had to prepare a proposal for like an in-hospital sim center, which may come up in future. Surgical decay is a real term. If you don't do it frequently, you will forget about it, or you'll skip the key steps. And in surgery, it's more common because I think in surgical simulation, everything is related to psychomotor skills. Like it's more like, unless you do it, you know why you are doing it, the steps. If you don't follow the steps, if I don't do surgeries for a week or maybe a month or maybe 6 months, the next day, even if I'm doing for the last 15 years, when I step into the OR, I will be underconfident. I will feel like, oh, well, I'll be able to do this, whether it's a simple surgery or a complex surgery. It just, you need to have that repetitive training model, which again depend on so many other factors which are just beyond one person's or one division's control. But I think that's a very important point. Simulation, if it not repeated, is of literally no use for I think any specialty. Yet you also mentioned the same, right? Like there's a significant attrition, and you'll think like, oh, like this should be not as much as in surgeries, but it's a significant number if you're saying 70 to 80%. So yeah, I mean, it's a real thing. Like the surgical decay or attrition is really, really a real thing. And that's why that paper, which I showed in 2023, I'm happy at least in US, they are doing it every week, every month. It's not a year-long phenomena, which I'm doing right now. And not me, like there are a few other surgeons across, like in UHN or across the city, they do these courses. But again, they're once in a year, right? Once in a year or once in 6 months is not going to cut it, in my opinion. So that's a big lacuna and a drawback, which talks to about, which basically tells you about the organizational or administrative setup, which needs to, or intention basically, which needs to be there for making this more frequent.
What I'm hearing from you is if I ever need neurosurgery, what I should be asking my physician is not how long you've been practicing, but how recently have you done this exact surgery?
Exactly. Nobody asked that question. Like, how many cases you have done? Yeah, I'm probably like 50, 60. That's fine. I mean, if you have done 4 years, even 1 year back, one particular simple surgery, you are already like, not, and this happens with many, many surgeons. They just don't accept it. They're like, if you leave them alone and keep them outside the OR and reintroduce them after 6 months, they will be different. They may not be the same. There will be, and surgery will still happen, but the micro, movements, the finesse, like the surgical finesse, will not be the same. And they know it, but this is something which is very, very uncommon. Like if there's a surgical lab here, and they give us full access to it, I'm not sure we all surgeons will go there, because they will say like, oh, why I need to do this at this stage of my career? I already know everything. So, and in my opinion, if there's time is also a problem, but all surgeons, middle-aged, young, early career, I mean, I'll just probably leave the most senior, professors out of this, but all of us can actually learn. If the models are good, you will actually like to do that. So it's a real thing.
Actually, that's a really interesting, the topic of the senior physician. Do you think that in the future could be a way to ensure recertification, ensure age-related changes are not affecting ability to have good I guess outcomes are going to be probably the most important thing, more so than sim, but
yes,
like just looking at the skills themselves.
So one thing which grapples neurosurgery, which I showed that video, but I think the sound was not clear, where you can say like and somebody actually last Department of Surgery rounds showed that video, and I found it from the internet because it was so closely like resembling what neurosurgeons think. They probably think that they don't need this. They already know this. I'm in practice for 30 last years. Like, I don't need to learn something new. I already know, and I can do it with my eyes closed. That was the video which was there to start with. It's if there is a recertification based on your acquisition and somebody is observing you and your steps for a particular surgery, I think there will be a lot of unexpected surprises you will see in their steps, because it's a surgical thing. Like they don't want in neurosurgery is more like it's related with your this psychology that everything, and then you will do it easily, and there becomes a part of your yourself which kind of resists that change, that no, maybe you need to learn as well. I think there should be a separate sim session for faculty and trainees. For faculty also, if there's a very good realistic model, I think they'll learn. And I think if there's a mandatory certification that you should have done these many surgeries under these different categories, I think it will help them even more. And as I said, like, routine surgeries, probably you don't feel the need. But what if, like, like that example of conjoined twins? I have never seen one, Mark. I have never assisted ones. And of course, I'm not a pediatric surgeon, but I'm pretty sure in pediatric neurosurgery as well, they have not done many, they have not seen many. So if that patient comes to you, you probably are like frozen because you don't know, and they are joined with one single venous channel in the center of the head, how you're going to do that. That's why probably there's highest mortality in these surgeries. And that's why I gave you that example where it was done through different continents, through virtual reality, and was successful. And why it's not successful that often? Because the techniques are not good enough. They're not trained enough to do what needs to be done.
So rare, yeah.
So rare, like once in a lifetime.
Yeah.
Like it's like, as I said, like I've never seen. I'm pretty sure, like those who are not in pediatric neurosurgery, they've never seen that kind of surgery. And those who are actually practicing, they may have assisted, they may have seen it occasionally, but they have not practicing it on not like even like once a year. It doesn't happen like that.
But you can refer, like if you're referred this patient, they come in by accident, you can say, look, this is not
100%.
yeah.
That's always possible, but again, we are talking about neurosurgeons. We don't refer usually. Say, like, I can do everything. Bring it on.
Oh no, I don't want to hear that. But that's okay. Yeah.
So that it's a specialty issue as well. And I say that's why I kept those slides. They think that they're like a little bit, they know everything, they can do everything, which is not true, which cannot be true. So I hope that changes in future, but that's how it is right now.
Yeah, thank you.
Okay, so it's almost 5. Dr. Kumar, thank you very much. And thank you all for attending, and see you in September with the new rounds.
Thanks, everyone. Mark, very nice to see you.
Nice to see you. Take care. Thanks.
Yeah. Bye-bye.
Thanks again, Fabian.
Bye.